everyone, I'm Tracy Merritt, and I'm going to present to you the basics of pulmonary function tests. During this presentation, our objectives are to discuss the purpose of pulmonary function tests, identify lung volumes and capacities, describe inspiratory and expiratory flow patterns, differentiate between obstructive and restrictive disorders, and at the end, we'll practice on a case. So what is the purpose of a pulmonary function test? Well, we use them to determine the presence and degree of certain diseases, lung diseases in particular. So for example, we would want to potentially identify an obstructive disorder, and we would recognize that by a flow limitation on our pulmonary function test. Or a restrictive disorder, which we would recognize as a volume limitation or a decreased volume capacity on our pulmonary function test. And of course, people can have both an obstructive and a restrictive problem, and we will recognize that as both a flow and volume limited disturbance on our pulmonary function test. Pulmonary function tests also help us recognize diffusion disorders, which are basically things that impede adequate gas exchange at the alveolar capillary membrane. We will save that discussion for another presentation. This presentation will focus on obstructive, restrictive, and mixed disorders. So let's review lung volumes and capacities. And a capacity is the sum of two or more volumes. When we look at this diagram on the left side, we can see that we're measuring lung volume in milliliters. And at the bottom, the x-axis, we are measuring time. The red drawing in the center represents a breathing pattern. So if we start right here where it says VT, tidal volume, we're inhaling, exhaling, inhaling, exhaling, normal tidal breathing. And when we're doing a pulmonary function test, we want to see what the person's normal tidal volume looks like. So we look for a baseline. We're going to use that baseline in our pulmonary function test measurements. Once we've identified a baseline from the person's normal tidal breathing, we will have them take a deep, deep breath in, as deep as they can. And this deep, deep breath is going to be forcefully and quickly exhaled as fast as they can. So we encourage them to exhale fast and hard and continue that exhalation until they feel like they can exhale no more. Once they feel like they can't exhale anymore, they will take a deep breath in or a regular breath in. It really depends on the person at that point or how you coach them. And the machine will recognize also when the flow has ceased and tell us that. You might have to repeat this maneuver a few times to get measurements that are repeatable. So from this diagram, let's recognize the tidal or the volumes that we have. Well, we looked at tidal volume already, normal tidal breathing. Excuse me. When somebody inhales past their normal tidal breathing, their normal tidal volume inspiration, any volume they can inhale after that is what we call inspiratory reserve volume. And you can see that here, represented as IRV. As that person exhales and exhales past their normal tidal exhalation point, anything they can exhale after that is considered the expiratory reserve volume. And of course, there's this residual volume that's in the lungs after expiratory reserve volume has completed. And that's the volume that ideally keeps alveoli patent. We can't measure that from a normal pulmonary function test. We have to do other things in order to measure that. And we'll talk about that at another time. So from these tidal volumes, we can create our capacities or identify our capacities. So we can start with total lung capacity, TLC, which is the sum of residual volume, expiratory reserve volume, tidal volume, and inspiratory reserve volume. Now we can simplify that by noting that TLC is also equal to the functional residual capacity, which is our FRC, and our FRC is the sum of residual volume plus expiratory reserve volume. Or we can also state that total lung capacity is the sum of residual volume plus vital capacity. And vital capacity over here, VC, is equal to the sum, it's the sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. Or we can simplify that, excuse me, and state the vital capacity is equal to inspiratory capacity and expiratory reserve volume. And if we move over here, we can see IC, inspiratory capacity, as the sum of tidal volume, and inspiratory reserve volume. So you want to get comfortable with this figure, draw it out, label it, play with it, be able to recreate it. Now, if we want to see what those volumes look like in the alveolus, this picture helps depict that. In blue here, you see the conducting airway, which is labeled anatomical dead space. And anatomical dead space is volume in the conducting airways or somewhere where that volume is not participating in gas exchange. And the circle below that conducting airway is the alveolus. And the blue here represents residual volume, the volume that's in the alveolus after complete expiration. In green here, this represents the volume of expiratory reserve volume. So that's the volume that somebody can exhale more after their normal tidal volume exhalation. Then in orange here, we have our normal tidal volume. You can see it's significantly less than the others. And when somebody breathes deeply, as deep as they can, the outside of this in the purplish color represents that inspiratory reserve volume. The vital capacity is shown here by the blue double arrow. And you can see that it is the sum of expiratory reserve volume plus tidal volume plus inspiratory reserve volume. So what keeps that alveolar space open? What keeps it from collapsing or popping? Well, this is a picture that's similar to the one on the previous slide, but it's depicting the forces at play. Here again, we have our conducting airways, anatomical dead space, and we have our alveolar space. In this particular diagram, FRC is represented as the hole here. And when there is 0 centimeters of water pressure in the alveolar space here, it means that there's no airflow. It means that what's in the alveolus is equal to what's on the outside of the body. There has to be a difference in pressure between the outside and the inside of the body for any kind of flow to occur. So in this situation, there's no flow happening. So what is happening when there's no flow at end of expiration? Well, if we look at the blue arrows here, they're representing these forces that are basically pulling that alveolus open, maintaining its patency. And the forces at play here come from the thoracic cage and the pleural space, and the pleural space. The green arrows represent that inward pull that brings that alveolus towards the center of itself so that the alveolus does not expand so much that it pops. So the blue forces are inhibiting that alveoli, those alveoli from collapsing, causing atelectasis. And the green forces are pulling towards the center of that alveolar space to prevent those alveoli from expanding too much and popping. Now, what about flow? So this is a flow volume curve, and it's a little difficult to interpret when you're new to it. So I'm just going to read through it, starting at the FVC spot here on the right side. So the bottom part of this curve represents inspiration. Excuse me. The top part of this curve represents expiration. If I've completely exhaled at this spot right here, I'm going to begin to inhale, 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 inhale. The peak of inspiration, I'm going to exhale. And you can see that at the beginning of expiration, that flow rate is significantly higher than the rest of the expiratory time. When we're looking at the inspiratory shape, it's more dome shape. It's more dome shape. So we are basically splitting that in half with equal flow rate on each side of the peak. Now, the numbers here are not super important. We'll get into them in more detail when we start talking about obstructive diseases and restrictive diseases and whatnot. But for now, I just want you to understand the flow pattern that comes with inspiration and expiration in a normal person. So what is obstructive and what is restrictive? What do these words mean? Well, when we talk about an obstructive disorder, we're talking about a disorder that is basically showing us there's a flow problem. Something is impeding flow in and out of the lungs, either during inspiration, during expiration, or both. And this flow problem can occur at the conducting airway level or the alveolar level. When it's occurring at the conducting airway level, it's because we have an increased airway resistance, which is represented here by RAW. And when we calculate RAW, it's the change in pressure from inspiratory to expiratory time divided by flow. Now, normally flow, represented by a V here, should have a dot over it. And situations that would increase RAW, which would cause a flow problem, are anything that would decrease the size, the radius size of the conducting airway, decrease its compliance or ability to expand, or decrease its elastic function, its ability to retract back to its resting state. So if you want to think about that from a practical standpoint, when somebody has bronchospasm, those smooth muscle cells contract and they squeeze the airway so the radius is smaller, that increases airway resistance. If there's mucus in the airway, that takes up space, so that decreases the radius. And when we talk about elastic function, we'll talk about tracheomalacia a little bit later, and you'll understand how that plays into this also. At the alveoli level, the main problem is decreased elasticity. So if there's a flow impairment that's due to alveolar disease, it's usually due to a decrease in elasticity. Now, elasticity is the inverse of compliance. So it's the change in pressure over the change in volume, where V is volume here. And this elasticity is determined by basically the health of the lungs and their histology. It's the ability of the lungs to retract back to a resting state or recoil back to a resting state after they've been stretched or after inhalation. So as somebody inhales, their ability to go back to that resting state is what we call elasticity. Surface tension, which I'm sure you've learned about before, also plays a role in that elasticity, because that surface tension is what helps move those forces towards the center of that alveolus. So you remember the green arrows in the previous slide. Restrictive problems we like to characterize as volume problems or compliance problem. Compliance is determined by the amount of pressure required to achieve a specific tidal volume. So it's calculating this change in volume over change in pressure. So if somebody has a decreased volume capacity because their lungs are stiff or there's something taking up space, we call that a restrictive disorder. And there's two types of compliance that we typically calculate. Static compliance, which is very independent of airway resistance, but it's very dependent upon the characteristics of the alveolar surface tension, the lung parenchymal health, and the thoracic cavity structure. So if anything is causing them to be stiffer, not being able to expand and accept volume, that causes a static compliance problem. Dynamic compliance is basically moving that air into the lungs to expand and be able to create or have that static compliance. So dynamic compliance is very dependent upon airway resistance, because if it's harder to pull air into the lungs because there's bronchospasm or mucus or what have you, then the dynamic compliance you'll see go down. It takes more pressure to overcome that airway resistance. But dynamic compliance obviously is dependent on static compliance also. So there's some other acronyms that we didn't talk about yet that are related to our pulmonary function test when we are differentiating between obstructive and restrictive lung disease. So this is a diagram that came from a published article that is representing the main volume measurements that we like to look at when we're differentiating between obstructive and restrictive disorders. So if we start at the top, FVC, which I mentioned already, stands for forced vital capacity. And this is the amount of volume somebody can forcibly inhale and exhale. Now, when we think about normal, of course, it's always based on ideal body weight and structure and gender, sex, etc. But in this situation, we'll just use 65, that should be milliliters, excuse me, I'll fix that. That should be 65 milliliters. Let's see if I can write on that. Per kilogram of ideal body weight. Let's see if I can write on this. Oops, excuse me. I guess I can. So just keep note that this is 65 milliliters per kilogram of ideal body weight, not 65 milligrams. Okay, so when somebody has an obstructive disorder, this forced vital capacity might be normal or high. Now, this is pure obstructive disorder. When somebody has a restrictive disorder, this forced vital capacity will be low. If they have a combined disorder, it will also be low. Now, FEV1 is forced expiratory volume in 1 second. This is the amount of volume somebody can exhale in 1 second. We expect somebody with normal lungs to be able to exhale 75 to 80% of their vital capacity within that 1 second. If that's not happening, if it's lower than normal, then they have an obstructive disorder. If they have a restrictive disorder, it could be normal to low. It depends. There's a lot more to it than that. We'll talk more about that later. If they have a combined disorder, it will also be low. Now, keep in mind that the FEV1 here is very dependent upon the FVC. So if somebody's FVC is low and the FEV1 was calculated or predicted based on normal lungs, the FEV1 will be low no matter what. So we won't use FEV1 all by itself. Okay, it's just here so that we understand what it is. Instead, we will use FEV1 to FVC ratio. This is more predictive of an obstructive problem. Okay, so for my class, we won't use FEV1 by itself to say somebody's got an obstructive disorder, because that's a flow problem, right? We must use it in relation to the FVC. Okay, so FEV1 to FVC ratio is our FEV1 percent. It's the ratio of FEV1 to FVC in that 1 second. And we expect it to be at least 75 to 80% in somebody who has normal lungs. If somebody has an obstructive disorder, it will be low. If somebody has purely a restrictive disorder, it will be normal, or it might even be higher. If you think I have difficulty expanding my lungs because I have a compliance problem, then they want to retract back more quickly. And we'll see that as an increased FEV1 to FVC ratio. If we have a combined disorder, it will be low. Now, peak expiratory flow rate here is, you guys have probably seen this when you're dealing with people that are asthmatic. We like to measure that to see if the bronchodilators are working. We measure it, it's low. We give them bronchodilator, we see if it improves, etc. So this is the flow, maximum flow during forced expiration. And I'm not going to give you a normal here because it's very dependent upon the device that you're using and other factors. But you do have an online calculator there if you'd like to play with that and get an idea. Now, if there's an obstructive disorder, the peak expiratory flow will be low. If there's a restrictive, it might be normal to high for the same reasons as the FEV1 to FVC ratio. If there's a combined disorder, it will be low. Oops, excuse me. Okay, so let's apply those acronyms or those measurements here. And this looks similar to the lung volume and capacity diagram that we saw earlier. Let me make sure my, okay, it's working still. Make sure my recording is still working. Okay, so this is a diagram that's similar to the one that you saw with the lung volumes and capacities, but here we're adding FEV1, forced expiratory volume in 1 second. So we're doing the same thing. We're inhaling normally. Here's the tidal volume. Inhale, inhale, inhale. Exhale. At the end of the expiration, we have them take a deep breath in, deep, 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 deep breath, and have them push as fast and hard as they can, push that volume out, and they keep pushing and pushing and pushing and pushing and pushing and pushing and pushing until you see a plateau here. And this plateau means that they've pushed it all out. And the machine will usually tell you that it recognizes that cease and flow. All right, so what do we do with this? Well, we like to figure out this FEV1, this forced expiratory volume in 1 second. So what we want to do is find our time at 0.0 during that peak of inspiration. And we like to put a point there. So we recognize where that is. And looking at the time, we will move over 1 second, and then we'll follow that 1 second line to our curve, and then we'll put a dot right there. All right, so we'll have a dot at the peak of inspiration, time 0, and a dot on the expiratory flow side of this waveform at 1 second. And looking at the volume by drawing a line across, and it looks like maybe it's about 1.5. And at the top, it looks like it's about 3.5. So that means that there was about 2 liters exhaled in 1 second. 2 liters. And we'll practice this a little bit more in a minute. Now, if we go over to the plateau part of the curve, we want to put a point there also, and also a point again at the peak of inspiration, because all of this volume that was exhaled to that plateau point is what we consider the forced vital capacity. And if we draw the line all the way across, it looks like we were about 0.5. At the end of that complete expiration, at the top, we were about 3.5. So we probably exhaled about 4 liters during this situation. Now our FEV1 was 2, but our FVC was 4. So 2 divided by 4 is 50%. That would mean we have an obstructive disorder. Now, we would have to do our math to determine whether or not the FVC was appropriate for this particular person. But more than likely, if we have a standard sized man and we are using 65 milliliters per kilogram by body weight, his FVC is probably low also. But we'll practice that in a little bit. Okay, so let's look at this again. And this is another diagram. I didn't draw this one. I drew the other ones, but I didn't draw this one. And if you just look at the pattern at the top, inspiratory, expiratory, tidal volume, they take that deep breath in, they hold, looks like they held a little bit, and then they exhale, pushing it out, pushing it out, pushing it out, pushing it out, pushing it out. Okay, so it looks like at 1 second here, they exhaled quite a bit of their vital capacity. But if we look down at the diagram below, still inspiratory, expiratory, tidal volume, and then we inhale, and then we push it out. Look how much slower that expiratory flow is for this particular person. And the FEV1 looks like it's significantly lower in that 1 second than the one above. So the one above represents a normal PFT. The one below represents an obstructive PFT. And we can see that by that decreased flow rate during that 1 second of time. Okay, now remember I was mentioning that the shape of this flow volume curve is really important. It can tell you a lot of stuff, even without looking at numbers. The one on the top is what you saw earlier, and it represents a normal looking flow volume curve. If we look down at the bottom here, if we have somebody that has early small airway obstruction, this would be somebody that has bronchospasm or narrowed conducting airways for some reason, you know, asthma, cystic fibrosis, things of that nature. That expiratory flow, remember here's inspiration, inspiration, expiration, that expiratory flow is decreased early on, and it's about 25 to 75% here. If we go up here and we look at the expiratory flow volume between 25 and 75%, you can see that it decreases for somebody that has early small airway obstruction. This would be somebody with asthma, cystic fibrosis, or somebody that's experiencing smooth muscle cell contraction or edema in their conducting airways. Now, if we go to the next one, this is somebody with severe obstructive disease, usually what we'll call emphysema at the alveolar level. And you can see that they might be able to get quite a bit out in the beginning, but at the end, it's really lagging. And they may not actually ever come to the point where they have completely exhaled because they are retaining air, or what we call air trapping. Okay, and then these others here, I'm going to do a little bit more detailed talk about these in a minute. Excuse me, this make sure it's still recording. Yeah. So fixed large airway obstruction, you can see here, when the person inhales, they actually plateau. They don't have normal inspiratory flow, plateaus. And then when they exhale, the same also happens. So this is an upper airway problem. When we look at a variable extrathoracic large airway obstruction, you can see that inspiratory flow plateaus, but expiratory flow can actually look kind of normal. We'll talk about this again in a little bit. And then the restrictive one is pretty obvious. Remember, this is flow on the y-axis and volume on the x-axis. And you notice that this wave, this curve, this diagram is skinnier than all of the others. And that's because this person has a restrictive disorder. So the volume measurement is decreased here. But just looking at the shape of the curve can tell you a lot. Okay, so let's talk about this a little bit more in detail. So on the left side here, we have a normal flow volume loop, and on the right side, we have a restrictor flow volume loop. So again, remember, we're starting over here at residual volume. We're taking a deep breath in, deep, 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 and then we push it out. Exhale, 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 and exhale all the way, and we meet our residual volume. So this is a normal curve. You notice that the inspiratory limb of the loop is symmetric, okay, and convex, but the expiratory loop is more linear. And specifically after the peak expiratory flow has been accomplished, then we've got more of a linear depiction here. In this situation, the maximal inspiratory flow, which is IF, maximal inspiratory flow here at 50%, is greater than the maximal expiratory flow at 50% because of the dynamic compression of the airways. Peak expiratory flow is sometimes used to estimate the degree of airway obstruction, but it's very dependent upon patient effort. On the other side, what we're seeing here is that we've still got the same shape of flow, just like we did in the normal one, but what is different is the volume, okay? So we've still got a configuration of a loop that's narrowed. It's still domed, but it's narrowed because of the diminished lung volumes, but the shape is normal. This diagram represents the difference between a lower airway obstruction, excuse me, versus an upper airway obstruction. So in the left side, we have a depiction of an emphysemic flow volume curve. So all the flow rates are diminished, inspiratory and expiratory flow, but expiratory flow prolongation is more obvious, it predominates. So in this particular situation, the maximal expiratory flow is significantly less than the maximal inspiratory flow. And what you're going to see is that the dome shape is still there on the inspiratory side, but when we get to the expiratory side, that peak expiratory flow rate is going to be significantly decreased. And then we kind of have a dip in that expiratory flow. It kind of curves in a little bit. On the other side, we have a fixed obstruction, fixed upper airway obstruction. So this could be tracheal stenosis, bilateral vocal cord paralysis, a voider that's causing compression, etc. And what you can see here is that when the person inhales, you can see a flattened or plateau of that maximal inspiratory flow. And then when we go to expiration, we still see a plateau of that expiratory flow. In this situation, though, the maximal expiratory flow and the maximal inspiratory flow are basically equal, are basically the same. The fixed obstruction limits flow equally on both sides, the inspiratory and expiratory side. So that's key. Okay, in this particular diagram, we have a variable extrathoracic obstruction versus a variable intrathoracic obstruction. So our variable extrathoracic obstruction could be like vocal cord paralysis. So just think about it. If there's one vocal cord that's paralyzed, it's going to move passively with the pressure gradients across the glottis. So upon forced inspiration, it's drawn inward, causing a plateau of lower inspiratory flow. And you can see that here. So we're inhaling, we've got this flat inspiration, that plateau of flow. And then when they exhale, it kind of gets pushed out of the way, and our expiration is normal. You see a normal looking diagram. The variable intrathoracic obstruction, and this would be an example of tracheal malacia, which I'll talk about in the next slide. Upon forced inspiration, the negative flow pressure holds the floppy trachea open. So our inspiratory flow is pretty normal. But when the person begins to exhale, the loss of structural support that allows the conducting areas to stay open is lost. And so you'll see some narrowing of this flow ability due to the trachea kind of moving and sometimes even collapsing. So what is tracheal malacia? It happens, what it is that somebody has lost the integrity of their supporting tracheal cartilage. So it's more flaccid. They also have a widened posterior membranous wall, and they will have a reduced anterior posterior airway diameter. These factors cause tracheal collapse. So when somebody's inhaling, it's okay, because remember the pleural pressures and the thoracic cage, everything drops and pulls things open. So it keeps that conducting airway open. But when somebody exhales, it doesn't have the structural integrity to prevent collapsation during that exhalation. So this collapsation can occur in kids if there's an airflow problem. I mean, when there's a need for increased airflow during coughing, crying, feeding, etc., anything that would require kind of a forced expiratory flow. In the pictures here, if you look at picture 1 up here, where the arrow is, it's a lateral chest X-ray, and it shows excessive tracheal narrowing. You can see that right where this arrow is here. In picture 2, you can see the trachea is open during inspiration, but during expiration, it closes quite a bit. So this is going to be a variable airway obstruction that you can see on a PFT flow volume curve. Okay, so some clinical pearls of wisdom, just to give you an idea of what to think. Now, these don't always hold true, but for the most part, they do. So if we're looking at a person and we think they have an obstructive disorder such as asthma, then we expect that their FVC will be lower because they're going to be trapping some air, and that causes a decreased lung capacity. They can't pull more volume in. Their FEV1 will be low, and of course, their FEV1 to FVC will be low. Their total lung capacity could be normal or high. So if it's high, it's because they are experiencing that air trapping. So they're not able to get all that volume out during expiration. In emphysema, the FVC, it can be normal or low. They are still going to have some air trapping, but it really depends on the degree of the emphysema. And we'll talk about that more next week. The FEV1 is going to be low. The FEV1 to FVC percent is going to be low, and the TLC is going to be high due to that air trapping that's usually common in people with emphysema. If we're talking about a restrictive order, in this particular example, we're seeing fibrosis, the FVC is going to be low, the FEV1 is going to be low, but the FEV1 to FVC will be probably high because you've got those forces wanting to bring everything to the center of the alveolus and pushing that volume out. And the TLC will be low. So even though these clinical pearls of wisdom here can be a little confusing because you see FVC is decreased in also the obstructive disorders, it's really because the capacity to pull more volume in is decreased due to air trappings. But the key to identifying obstructive disorders is that FEV1 to FVC. Okay, if it's low, you have an obstructive disorder. The key to identifying a restrictive disorder is that FVC. If it's low, you're going to have a restrictive disorder. Okay, So let's do a case study. This is a 54-year-old man who's complaining of increasing dyspnea upon exertion for the last 6 weeks. Sorry for the typo, I will fix that. He has a strong productive cough. Recently, his pulmonary status has deteriorated to the point that he cannot work. He was employed as a cook for several years, but has never smoked. Upon physical exam, his heart rate's 110, BP is 148/76, respiratory rate's 20, and his temp is 100. So he's a little hyperdynamic. His heart rate's a little high. That could be because he's dyspneic. He doesn't feel good. He's uncomfortable. His blood pressure is on the high side also. Again, it could be a sympathetic response from the stress that he's experiencing. Of course, as a practitioner, you want to begin to brainstorm what are all the things that can cause the heart rate to be high? What are all the things that can cause the blood pressure to be high? But for now, let's just think about it. Could be a stress response due to his dyspnea. Same thing with the respiratory rate. Temperature is 100 degrees Fahrenheit, which is high for an adult. So again, you would want to brainstorm what are the types of things that can cause an increase in temperature. Here we could start thinking infection. Maybe he's got pneumonia. Maybe he's got a viral infection. So usually viruses don't show up with a fever though. That's not always the case. But you can also think about other things like volume status. Upon percussion, his lungs are mildly hyperresonant, so that tells you there's probably some air trapping. Upon auscultation, his breath sounds are diminished throughout with tight expiratory wheezes. So that tells you that he has a flow problem. That wheezing represents a decrease in the conducting airway radius. So is this from bronchospasm? Is it from inflammation? Is there an obstruction like mucus or something else that's causing this? And the diminished breath sounds pretty much go hand in hand with emphysema. Not always, but for the most part. Upon inspection, he has an increased AP diameter, so that's anterior posterior diameter, and digital cyanosis. So the fact that his AP diameter is increased tells you that he probably is somebody who has emphysema that has trapped air, and his thoracic cage has remodeled to accommodate that trapped air. Digital cyanosis usually means that they are hypoxemic. His blood gas is pH of 734, CO2, PaCO2 of 75, PaO2 of 65, and a bicarbonate of 35.5, and his stat is 90%. And this is on Romero. So he doesn't seem too hypoxemic for somebody with emphysema. It's a mild hypoxemia, but he definitely seems to have chronic hypercapnia because his CO2 is high and his bicarb is also high. So if you want to know more information about this, please feel free to reach out to me. And also on infection, his IE ratio is 1:4. That means that his expiratory time takes 4 times as long as his inspiratory time. So the physician asks you to do a pulmonary function test on this person. So you do a basic one. We're just going to do a basic one for now. And this is what you got. So you have the volume on the left side, the time on the bottom, the x-axis. You had the person breathe normal tidal volume until you got your baseline. And then you had him take a deep breath in, as deep as he could. And then you had him exhale as fast and hard as he could until you reach plateau, which seems like it's way over here past that 20-second mark. Okay, so how would we deal with this? Well, let's look on the next slide. Here we go. This is your same PFT. And what you did is you wanted to identify the forced vital capacity right here. So remember, our lowest accepted norm is 65 milliliters per kilogram of ideal body weight. Well, he's 180 pounds, and if you divide that by 2.2, that gives you 84 kilograms. So your predicted or expected FVC for this person is 65 mils times 84, which gives you 5,460 milliliters. Well, let's convert that to liters because it's just easier to deal with. So you basically divide 5460 by 1,000. You can see that down here. So your predicted FVC for this person is 5.46 liters. Okay, so let's see what we got. So when you look at your diagram, you want to find the very peak of inspiration, and you found it at about 5.5 over here on the left side, the volume. But you also want to find where was the end of expiration, where it began to plateau, and you found it way over here past this 20-second line. Draw the line across. It looks like it's landing on the graph at about 2.25. These are in liters. So your forced vital capacity is 5.5 minus 2.25. That gives you the volume in this area, which equals 3.25 liters. So you put that here as the measured, all right? So let's see how this pans out. Well, the percent predicted is calculated by taking what was actually measured, what you actually performed, and that's 3.25 liters right here, and then divided by your predicted, which was 5.46. So if we divide 3.25 by 5.46, that gives us, oh, there should be a point right here. I'm sorry about that. That should be 0.63. Divide times that by 100, that gives us 63%. I will fix these typos before I save this for you guys. So this person, FVC, was only 63% of what we predicted it to be for normal. That means he has a restrictive disorder. Okay, so then you say, well, what about his flow? He's got a low FVC, his volume is low, he has a restrictive disorder. What about his flow? So your FEV1, as I mentioned before, you can't really use it by itself. So if we were predicting it, it should be 4.37 liters because it should be 0.8 of the predicted FVC. So that's what's predicted. Let's measure and see what we got. So you found the peak of inspiration here, okay? And you drew a line down to find out where that lands on the time. And it's about 8.5. So you put a dot at the top, find your 0 second, move over 1 second, which is going to be 9.5. Draw a line up till you hit the curve. Put a dot there. From these dots, you can draw a line all the way to the left to see what that volume exhaled in that 1 second was. And it looks like we're landing on 4.5 here. And our peak of inspiration, we knew already, was 5.5. So our FEV1 is equal to 5.5 liters minus 4.5 liters, which is 1 liter. So we put our 1 liter here in our measure. Now, obviously that's less than what we expected, but we're not going to use that because we have to relate it to the actual FVC. And we're doing that by looking at the FEV1 to FVC. So we expect it to be, greater than 80%. And we can put 75% here too, 75 to 80%. So when we do the math, we want to take 1 liter, which is what we measured as the FEV1. Oh, excuse me, there's a typo here. And 3.25 liters, which is what we measured here. And I'm going to do the math real quick to make sure. So 1 divided by 3.25 is equal to 30.76. So that's basically 31%. So I'm going to change this. I apologize for this error here. So our FEV1 to FVC ratio is actually 31%. Well, that's really low, definitely lower than 75 to 80%. So that means we also have an obstructive disorder. So your person has a restrictive disorder and an obstructive disorder. And then from that point, we want to figure out, well, what are those disorders and how can we help this person? But that'll be later when we work on our case studies a little bit more. Okay, so in summary, PFTs are used to identify restrictive volume, obstructive flow, or mix and diffusion problems. Obstructive disorders are characterized by a decreased FEV1 to FVC ratio. This is the flow through the lungs. This can be decreased because of increased airway resistance or decreased elasticity. And restrictive disorders are characterized by decreased FVC, lung volume capacity at the given pressure, AKA compliance. All right, so I hope you enjoyed this. Please feel free to reach out to me if you have any questions. And I will be fixing those typos before I save the PDF for you to use along with this presentation.